product of UCSD. Before I was a psychology major, I started out as a structural engineering major at UCSD. So continue to just collect UC schools as I go throughout my career. So yeah, thank you so much for the kind introduction. I am representing the Dissemination Implementation Unit, or the D&I unit of the ICTS. And so I'm going to give sort of an overview to dissemination implementation science. So some of my sort of objectives and agenda here, start with some introductions. I know we have like a slightly larger group here. So there's a couple of places actually where I'll be asking you all to use the chat to respond to some things, and we'll do that for introductions as well. But I want to provide an overview of what is dissemination and implementation science. My goal today is not to convince all of you to be D&I researchers, or even that this is an area that you want to pursue research in, but I think it's useful to know what is dissemination implementation research, what is, what's going on in this activity, to sort of figure out, is this an area you are interested in? Should you be collaborating with people like this? Or at least maybe when these funding mechanisms come up and people are talking about D&I work, you realize, oh no, that's not what I'm doing, but I'm having a clear understanding of it. I'm going to talk a little bit about my own work, just very briefly, just to give kind of an example. And then I want to talk about D&I funding at NIH, because I know that, all of you are sort of thinking about your own independent research career. How do you apply for grants? How do you apply for projects? How do you get sort of started? How do you create yourself, establish yourself as an independent investigator? And I do think that, one thing that, was mentioned earlier has been exceptionally helpful for me as I've sort of advanced in my career, is having just a great network around me of people who've helped me sort of navigate the process. And so even if, you decide you don't want to go into dissemination implementation work, I think that some of the general principles of navigating the sort of NIH alphabet soup and some of that process is translatable in other areas as well. So, I'm going to be giving examples in dissemination implementation, but I think that all of you can probably apply it to your own pursuits of NIH funding. And then, we have a really great long, length of time here together. So I do want to make sure we have some opportunities for questions and answers and follow-ups. All that being said, I don't want this to be overly formal. Feel free to raise your hand, to add questions in the chat, to unmute yourself. If you have clarifying questions, or even if there's some aspects you want to discuss a little bit more about specific points as we go throughout the webinar today. Any questions before we get started? Cool. I'll also note I'm a clinical psychologist, and so I'm very comfortable with long silences. So I can wait you all out. But, as mentioned of some of my objectives, to learn what is dissemination implementation science, to be able to identify dissemination implementation questions related to your projects. I really want, even if you're not sure how you would design the study at this point, even if you're not sure, exactly how you would be able to, measure some of these things, at least if you can sort of think about like, well, that's a dissemination implementation question, that would be help you sort of be able to come to me, to come to other folks in the D&I unit, or to connect with other dissemination implementation scientists to help support the work. So I think just understanding what is a dissemination implementation question is really the necessary first step. I'll talk somewhat about models and outcomes, but I also just want to hope people have fun and learn something new today. So hopefully you'll be able to take something away from today's session. So I want to start with intros, and unfortunately, due to the size of the group, I don't want to go around and do this, over voice, but if you could just put in the chat your name, your affiliation, and what's one thing you want to be able to take from today, that would be really useful for me to get to know sort of the makeup and the composition of like who's in the Zoom today, as well as potentially you to get to know each other. I think one of the things that's really great about having these ICTS types of webinars and workshops is the ability to connect with people from other schools, other departments, other disciplines, because I think that really having truly interdisciplinary spaces and interdisciplinary teams is really what's necessary to move the type of the work we do forward at this point. And so as a model of an introduction for myself, as mentioned earlier, my name is Schueller. I have affiliations both in the Department of Psychological Science as well as the Department of Informatics. And, I really want to learn what you all learn. So, one of the things I'm really interested in at the end of today's session in the question and answer is what some of you guys are taking away from the session. And I think that that's always been really informative to me as I've done some of these different workshops on dissemination and implementation science generally, and also through the ICTS, is going to different disciplines and going to people with different levels of knowledge or background in this area and learning, what you all are taking away from things, because I think sometimes it's lessons that are not entirely the ones I always anticipate, which I think are helpful as well. So I'll pause a second for you all to think a little bit about what is it you want to be able to take from today. I'm also looking at the chat so I can get a sense of who's here and what they're hoping to get out of it. It's also great to see some familiar faces and names. And so if you already know me, it's thanks for coming and thanks for connecting here, and thanks for your interest in learning more about dissemination and implementation science. Cool. Well, I'll let people continue to introduce themselves. I'll actually move on to some of the framing here, in that I think one of the reasons why we're seeing more interest in dissemination and implementation science, we're seeing this at the NIH level, that there are considerably more resources and funding that's being devoted to think about dissemination implementation. I think we're seeing this in the dialogue around sort of biomedical science and the challenges with getting things into, to benefit people's lives, is that there's a significant research to practice gap. We, in our research labs, in our research settings, we do a lot of things that actually never improve the lives of the people that we want to improve. And so implementation science and dissemination science are really responses to try to think about how do we actually take some of the discoveries that happen in our laboratories, that happen in our research labs, that happen in our academic medical institutions, where we have a lot of the resources and we have a lot of the infrastructure, and how do we move that into the different settings where they can actually have an impact on people's lives. Before I get into teaching you all more about dissemination implementation, I want to start a little bit with a quiz. So if you can put in the chat just the answer, your answers to these two questions. How long on average do you think it takes for original clinical research to benefit patients? And this is a statistic that's actually cited often, so some of you might have heard this number before. But the second one is actually one I'm also really interested in, and I think doesn't get talked about as much. So question number 2, what percentage of original clinical research do you think makes its way into practice to benefit patients? So just in the chat, the answer to these two questions: how long does it take on average for original clinical research to benefit patients? And number 2, what percentage of original clinical research do you think makes its way into practice? I see 17 years, and I see 25 years, and 0.1%, 20 years, 0.2%, 10 years and 0.1%, 15 years and 1%, 7 years and 10%, 1 to 5 years and 10%. Cool. Okay, so I see a lot of guesses. So I will say, overall, you guys are pretty good on the length of time. 17 years is the statistic. It's usually cited. 17 years to move from our original clinical research into practice that will benefit patients, and about 14% of clinical research. So you guys are maybe a little bit more pessimistic about the state of the research. And maybe that's kind of framed as, as I'm coming in and telling you about how dire it is in this research to practice gap, that it is pretty small. So, of all the work that we do, if you think about all the studies, all the papers you publish, only 14% of original clinical research actually makes its way into practice. And on average, it takes about 17 years to be able to do so. So why? Why do you think it takes so long, and why so little clinical research makes its way into clinical practice? What would be some of your answers? And feel free if you guys want to unmute yourself. I'd love to hear some of your thoughts around what you guys see as some of the barriers in your own work or barriers you've seen in terms of, in the field about some of the things that slow this research to practice translation. Any thoughts? Feel free to raise your hand, unmute yourself, type in the chat. Unfamiliarity with regulatory pathways, so that there is a lot of knowledge that we don't have about, things that kind of lead to the adoption or the uptake of things, and regulation is one of them. Yeah, for sure. Other ideas? Money, lack of sustainable business model.
Practitioners don't see the relevance or don't think it's valuable.
Practitioners don't see the relevance. I think I'll also throw that one in its head. Maybe researchers don't ask research questions that are practically relevant. So, I think it's a two-way street, but yeah, totally. I think that's a major challenge. I see scalability. And I think that one of the things that, we talk a lot, that gets talked a lot about in dissemination implementation research is scaling up. How do you actually take things from smaller settings and, move them to, more settings? How do we go from like 1 clinic to 5 clinics, 5 clinics to 20 clinics? I think another sort of challenge with scalability is a concept that a colleague at UCSD has written a little bit about, Greg Ahrens, which is scaling out. How do we actually take evidence that was generated in a certain setting or population and move it to other settings or populations? So although we did this, this research with African-American sample, do we know it's going to, generalize to Latinos? If we do this certain intervention in a primary care setting, would it work in a community health center? A variety of different things around that. Knowledge around patents and licensing. So yeah, there's a variety of different aspects that you guys are all highlighting that lead to some of the challenges between taking interventions or ideas from clinical research and moving them into clinical practice. So I think one thing that's actually been noted a lot as one of the challenges that, slows down this move from clinical research to clinical practice is that our traditional development pipeline has been quite linear. So, often we talk about translational research, especially translational research at NIH, and, there's different levels of translation. So, this is the typical pipeline that we started with. We would do preclinical research, and this is often, could be animal models or things that nature, sort of basic science. Once we sort of establish that, we would then move to efficacy studies. So this is T1 translational research, in which we would evaluate an intervention or a clinical innovation under sort of tightly controlled sort of research infrastructure. We then move to effectiveness research, in which we're actually testing things more in real world settings. And then after that, we would engage in sort of T3 research or implementation research about how do we actually move it in. And then ultimately, that's hoping to sort of move to improve public health. And I think what we've recognized over the years is that this is a slow pipeline and this is a leaky pipeline. So that, one of the challenges that occurs here, this is the 17 years to, clinical practice, is that a lot of research, for whatever reasons, doesn't make it to the next stage. Either the research team doesn't have the expertise to be able to move that ahead, and, that they don't, they can't find sort of partners to be able to move it to the next stage of research. That, maybe some of the things that we sort of identified in these earlier research steps don't make it. So, the preclinical research may not work in, sort of human models. The stuff that we do in sort of tightly controlled research settings may not generalize to actual clinical practice settings. Or we might create an intervention that is really effective, but no one wants to pay for it or no one wants to use it. And so ultimately, like, implementation gets slowed down or stopped because of that. So, I think that what, implementation and dissemination science is really focusing on is that this traditional development pipeline is not going to be sufficient if we want to see improved public health benefits. And so I think there's a variety of different things that are going on in this field. Focus on designing for implementation, focus on doing hybrid effectiveness implementation studies that simultaneously test effectiveness implementation aims, which I'll talk a little bit more about later. But a variety of different things that sort of help reconfigure this development pipeline in a way that is more iterative, more agile, and more responsive to actually moving research into clinical practice. So what is dissemination and implementation science? This is a definition that was part of the inaugural issue for one of the leading journals in this field, which is called Implementation Science. And they defined dissemination implementation science as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence improve the quality and effectiveness of health services. A couple things I want to note about this definition, and I want to kind of offer sort of simplification and another way to kind of describe this field. But one thing to note is, like, as I mentioned, this was the inaugural issue. This paper was published in 2006. So this is still a very young science. This is still a developing field. This is one reason why I'm really excited and I really like dissemination implementation science, because it is so new. And so I think that there is a lot of opportunity for sort of new discoveries, new research, new opportunities. I think another thing to sort of note is that, it's about the scientific study of the sort of process through which we implement these research findings. And so there is a difference between dissemination implementation practice, which is, moving evidence-based practices into routine practice care and healthcare settings, and dissemination implementation research, which is trying to understand the systematic translation. So, there is a field that's focused on sort of the practical side of this, and there's a field that's focused on the scientific side to try to create principles and ideas that can help us more quickly, more effectively, more efficiently move clinical research into clinical practice. So this is another, weird, my slide's not showing up here. Give me just 1 second. That's funny. I'm going to fix my slide in a moment. Okay, good to go. Cool. Okay. So this comes from a paper that Jeff Curran wrote back in 2020. And I really like this definition. It really helped me in my own sort of development, sort of just better understand, what is implementation science and what is it we're evaluating. And the other thing I love about this paper and this image is that Jeff Curran gave this talk a couple different times. I think I saw it in 2017 or 2018, and he literally just took his PowerPoint slide from his talk and put it as the image in his paper. So this is the blue PowerPoint slide that Jeff used to describe this. But his sort of reframing of implementation science to make it really simple to think about, like, well, what is it we're actually studying in this field as a scientific endeavor? Having some very non-scientific language can actually be pretty helpful, so that the intervention, the practice, the innovation is the thing. And that effectiveness research, clinical effectiveness research, looks at whether the thing works. Does this new medication work? Does this new therapy work? Does this new device work? And that's what we're typically doing in clinical effectiveness research. Implementation research looks at how best to help people or places do the thing. So how do you get more people to prescribe a specific medication? How do you get certain clinical psychologists to be more adherent to an evidence-based practice? How do you get a certain nurse practitioner to refer people to a specific type of care? Work that we're trying to figure out on how to get people to do the thing, to do the clinical innovation practice or intervention, that is implementation research. And that implementation strategies are the stuff that we do to try to help people or places do the thing. And implementation strategies are what the area of focus is when we think about sort of implementation research. So we're trying to understand the impact of the stuff we do to try to help people or places do the thing. And that the main implementation outcomes are not clinical effectiveness outcomes, but instead we want to know how much or how well they do the thing. So, how often are nurse practitioners referring? How adherent, how much fidelity do we see of clinical psychologists to the sort of certain evidence-based practice manual that they're supposed to be providing? How do we sort of understand the quality or the quantity of the innovation that individuals in those settings are provided? And so that I think that if you sort of reconceptualize or just use this language about when you look at a sort of setting or you look at a sort of study, like what is the thing? What are we doing to help people do the thing? And how do we sort of understand the outcomes, the results of those strategies? I think that that's how we can frame something as an implementation research question. So that it's not about looking about whether the thing works, that's effectiveness research. It's looking at how best to help people or places do the thing. Any questions on that? I'll pause there for a second. Oh no, I have another empty slide here. Oh no, there we go. Cool. It's animation. So, I want to kind of go back again to think about like some of the challenge with why we don't see more things move into practice. And I want to, talk again about like how do we situate implementation dissemination research vis-a-vis sort of traditional clinical research. So I think in our traditional research paradigm, is mentioned, this is effectiveness research, that we have a clinical intervention. This might be a treatment, this might be a program, this might be a practice. And we're trying to understand the impact of that clinical intervention on different aspects of patient outcomes. So we think about sort of symptoms, we think about quality of life, we think about recovery. And that, if we, in the best case scenario, our intervention, our sort of innovation leads to improvements in patients' symptoms, quality of life, or recovery. And that we go and we publish our paper, hopefully in a good journal like JAMA, and then we kind of go back and we develop another clinical intervention, or we do another study of a different clinical intervention, and we just kind of repeat this process. We evaluate an intervention, we see outcomes, we publish a paper. And what implementation research is focused on, and dissemination research, is on sort of the completely other side of these types of things. So, as mentioned earlier, how do we sort of think about implementation interventions? So strategies such as planning, engaging, executing, reflecting, and evaluating. And that's a very sort of cyclical, iterative process. These lead to implementation outcomes, things I mentioned like fidelity of delivery, penetration. So, how many people within a healthcare system are actually engaging in a specific practice. Things around sustainability. Does something get maintained over time, especially when the processes that we do in research are kind of taken away? And those translate to patient outcomes through different service outcomes, things such as efficiency, safety, et cetera. And that in doing so, one of the things that leads to or impacts a lot of these service outcomes are different aspects of the contexts. These can be things that are really proximal to the clinical interventions and the implementations, the healthcare systems, the centers, the teams, or these can be things that are less proximal, sort of the outer context, the outer setting. Things that are such as, policy, reimbursement, payment, marketing, those sort of aspects that I saw a lot of people sort of mention in the chat as we were talking about some of the challenges in terms of moving clinical research into practice. And so I think one thing that, is really a characteristic of implementation research is that it's very multi-level, multi-systems. As mentioned earlier, I live in the School of Social Ecology here. And so, this is like music to my ears in terms of thinking about the social ecological models. But I think it's just a recognition also that clinical interventions and clinical innovations don't happen in a vacuum. They don't happen entirely in a laboratory. And you can have the best intervention, the best innovation, the most effective thing, but that if individuals don't actually use it, if individuals don't take it, it's not going to have a public health impact. And I think that we see I think, for example, vaccinations, especially in light of the COVID pandemic, I think has been a real, important recent case study for implementation science, because it really is sort of that last mile, or, getting the shots in the arms, which can often be some of the most challenging parts about actually making sure that these tools, these like amazing examples of clinical innovation in science actually lead to a public health impact. So if people don't use your treatment program practice, despite, no matter how good or effective it is, it's not going to ultimately lead to health improvements in real world settings. So, implementation science sort of considers the entire sort of aspect of these different stages to sort of think about how do we actually lead to improvements and betterment in people's lives. And implementation research specifically thinks about this side of the equation. So, we take things that are already demonstrated with clinical effectiveness and effective interventions, and we sort of think about how do we evaluate the strategies, the context, and implementation outcomes. So that's sort of like a really broad overview of what is implementation science and what are some of the goals of dissemination implementation research. I want to move and talk a little bit about some implementation frameworks to help us sort of better understand, like, okay, if I can start to frame a research question, or at least know what implementation research is, what do I actually look at? How do I understand, something about how to better get people do the thing that helps me create a research question that's going to lead to better uptake of a clinical innovation into practice? And, largely implementation and dissemination frameworks are divided into two broad categories. I'm not going to be able to go through all the different dissemination implementation models and frameworks in today's workshop. I want to provide, an introduction to some prominent ones, but I do think it's useful to sort of note this distinction between the two types of frameworks that we typically see in this field. So there are determinant frameworks that talk about the characteristics of the innovation itself, or the characteristics of determinants that lead to implementation success. So these can be characteristics of the context, of the organization, of the people who would be using it, the users, of the innovation. So things that kind of describe, like, why would something be successful or not successful if we tried to implement it, and really understanding those different aspects, the determinants. And then there are frameworks that think about the implementation process. What are the different steps that go on when implementing, and how do we sort of better describe and understand those processes? So determinant frameworks sort of understand what are the characteristics of different things in the ecosystem that lead to implementation success. And process frameworks are frameworks that better understand, or try to understand, sort of the implementation process. And for different studies, for different questions, for different stages of implementation research, you might want to use a determinant or a process framework. In some instances, you might use both a determinant and process framework, but I think it's useful to kind of think about, like, am I trying to understand characteristics that lead to success, or am I trying to better understand some aspect of the innovation process? And that's one way to help us sort of sort and think about, like, which framework might be the best framework to use. One of the most prominent and prevalent implementation frameworks is what's known as the Consolidated Framework for Implementation Research, or the CFIR model. This was a framework that was created by Laura Diamschauder. And the way that they came up with the CFIR model is they actually did a systematic review of different implementation frameworks that are out there to look at, like, what are some of the consistent things that are present in those different frameworks, and they combined them into this consolidated framework that's not meant to be, you know, completely exhaustive, but is meant to be sort of representative of the general features that are present in other frameworks. I'll also note that I think one thing that is, you know, because it was this sort of systematic review and this combination of other frameworks, the CFIR framework has both aspects of a determinant framework as well as a process framework. There are 4 domains that focus on sort of determinant issues. There are intervention characteristics, there are outer setting characteristics, there are inner setting characteristics, and there's characteristics of the individuals. So determinants are sort of thought about like some aspect of the clinical innovation, some aspect of the setting, some aspect of the people involved. And each of these different domains have different subdomains or sub-aspects that are evaluated or could be evaluated in CFIR. And then there's another domain, process of implementation, that looks at different aspects of what's going on in the process. Things such as planning for implementation, engaging different actors in the implementation process, executing, actually going through the process of trying to implement something into the care setting, and then reflecting or evaluating on the implementation success or the implementation failures that occur. So, you know, the CFIR framework is a framework I really like. It's one that I use in a lot of my research and the studies that I do. You know, I think when I look at an implementation project, or when I'm thinking or planning with someone else, I'm often kind of thinking about like different CFIR domains to think about like, well, what are the domains here that are present in terms of this research that we're doing? I also want to note that although it's a, you know, very broad framework that covers a lot of different aspects, that doesn't mean that when you do a CFIR project or do an implementation project, you have to make sure that you're addressing all of the different domains, or especially not all of the different subdomains. This was a paper that what they did is they looked at different studies that were using the CFIR framework and which were the aspects that were being most commonly addressed in that research. And I think a couple things I want to sort of point out here that I think are useful to describe the field, but also useful for us as researchers to think about how we might be able to apply the CFIR framework to the work that we do. So the first thing I want to note is that if you look across the domains, there seem to be some areas of study that are more commonly addressed in implementation research. So understanding the characteristics of the intervention, the characteristics of the individual tend to be some of the most commonly looked at determinants. We see that there tends to be sort of less research on the outer setting, these things that are sort of more distal from the actual implementation process, and more research that's being done at the inner setting level. So, you know, I think what this kind of suggests is across implementation research, we see better understanding of certain aspects of these different domains. And then even within a domain, we see that there are some areas which tend to be more commonly sort of evaluated. So like complexity of the intervention and the innovation is one of the most, commonly studied things. And I think, it's in some ways not surprising, like complex interventions are probably harder to implement than simpler interventions. And so understanding intervention complexity, I think, is something that is, a sort of reasonable place for intervention understanding sort of uptake. Whereas we see less consideration of like costs or design quality and packaging. So I think, again, these kind of speak to that, we all sort of appreciate that these are potentially important aspects for, people taking up our clinical innovations. But these are often not things that we're well trained as, biomedical researchers. In my own area of research, as mentioned earlier, I do a lot of work in digital mental health and using technologies to expand mental health services. I've been spending a ton of time lately trying to better understand billing codes and processes for getting billing codes created and approved. Not because I'm terribly interested in billing codes, but because I've started to recognize that if we want to be able to translate these tools into practice, someone needs to pay for it, and someone needs a way to be able to actually sort of reimburse that payment in sort of our traditional sort of medical billing processes. So I think that this, again, really kind of points to the need for like really interdisciplinary teams if we're going to be able to move this work into practice. Because, as mentioned, I don't have knowledge in billing codes, and it requires me to sort of understand better, people who do, and, start to think about some of that work. So I do think that, one thing that is characteristic of implementation research, and if you start to go down this this pathway, is it does start to take you in directions that might be kind of different from the research that you're used to and the process that you're used to doing. And so I think for some people, I think that that's often like really rewarding and really, interesting. So maybe if you're doing sort of basic early stage clinical research, starting to create some like patient advisory group, so you can better understand like the needs of patients who might be dealing with a certain condition that you're thinking that your sort of clinical innovation might be able to address, and sort of better understanding what some of their concerns are, and different things that might sort of lead to different ways that you might think about doing the discoveries you're pursuing. But for other people, that might be taking you out of a lane that where you feel like you're best suited to sort of investigate and to do your research. So I think it's just, as mentioned earlier, like my goal for today is not to transform everyone into dissemination implementation researchers, but to help give you a flavor for the work that's going on here, to better understand and think about if this is a place where you'd want to be doing your research and doing your work. I'll stop here for a second to see if folks have any questions, comments. Oops. Sorry, my toolbar disappeared for a second. Any questions or comments before I move on? Feel free to put things in the chat or raise your hand.
Hello, can you hear me?
Yes.
This is Adam speaking. So I'm wondering if conducting the implementation research would drive the science, and is that considered ethical or is it not? Say, for example, after doing the implementation research, you found out that the implementation could be very complex and difficult. Would you still conduct the research and the science to develop such treatments? And forgive my heavy breathing. I'm in the gym. Thank you.
Yeah, I mean, it's a really good question. And I think that, one of the things that I think is important to sort of appreciate is that we do need different types of research. We need applied research, we need basic research, we need translational research. And I don't think that, calling for implementation research is suggesting that like there's no basic science research that's necessary. I do think there are times when one might be, considerations from the implementation side that might suggest like a certain, pursuing a certain pathway or not. And then I think maybe that takes us away from doing, pivoting earlier on to not engage in some research that, would not be potentially impactful in the way that we think it would be. So, maybe like a little bit more of a case example of kind of what I'm thinking about there. So imagine you're developing a new drug for a certain condition, and in terms of some of the basic research, you understand that there might be a sort of specific side effect profile that might be present of that medication. If you eventually are able to kind of create it, just based on the mechanism of action that you're focused on. It could be sort of useful to sort of understand at that phase, like, would those side effects be acceptable to the types of patients that are dealing with that condition? And also, like, what is the sort of potential need for a treatment in that condition? And would the new benefits compared to some of the other things that are out there be, more or less sort of acceptable? So you can see on the CFIR model, the second row down from the top under intervention sort of characteristics is relative advantage. And so what relative advantage means is like, what are some of the other interventions that are present for this, in this space? And what are the benefits of this intervention, this new intervention versus those other things? So if you're developing sort of a new drug and it's got, it's in an area where there's a lot of other treatments that are present and it has a side effect profile that's, not that desirable, especially, for that certain target population that deals with that condition, that's not an intervention that is going to have like a lot of relative advantage. It's going to be, hard to implement. It's going to be hard to convince people to do. And so maybe it's like, okay, well, maybe that's not the best mechanism of action to pursue. So I think, that would be the implementation argument. I think on the flip side of that, there's lots of basic science discoveries that maybe we don't know where it's going from the start. And, we're not entirely sure where the application might be. So, I think that we have to balance those things. It's not that we, need to get rid of, research that we're not entirely clear where it's going. But, I think we need to also be asking ourselves sometimes, where do we see this going? And, what is the potential when we get to the, this last stage about where some of the barriers we're going to be facing to eventual uptake and, from the patient level, from the provider level, from the system level, as we're developing those things. Does that make sense? Does that answer your question a little bit?
It does. Thank you so much.
Perfect. Cool. Thanks. And thank you for the question. I appreciate the engagement. Any other questions? Otherwise, I'll move along. Cool. So moving along, I want to talk a little bit about implementation strategies, because as mentioned, implementation strategies are the active efforts that we take as a health system, as implementation experts, as policymakers, as people who are trying to get more people to do the thing. So we can have, again, going back to the terminology I used earlier, the clinical or preventive intervention is the thing that improves people's health. Implementation is doing the thing. So that's implementation practice. Implementation research is how to best do the thing. So how do we sort of better understand what are the efforts we can take to get people to do the thing? Implementation strategies are actions that change agents take to help other people do the thing. So what can we put in place as a health system, as a employer, as a policymaker, as an implementation expert? What are things that we can do to help people do the thing? And then implementation outcomes, which I'll talk a little bit about later, is how much or how well did other people do the things? So to, again, think a little bit about well, what is the difference between an intervention or a strategy? interventions are evidence-based clinical or prevention of interventions that usually fall under these 7 Ps. Their pills, their programs, their practices, their principles, their products, their policies or procedures. So I think, any of the clinical innovations that all of us are thinking about probably eventually will, if they're going to get packaged in a way that's going to try to be provided to a patient, provided to a person, is going to be a pill, program, practice, principle, product, policy, or procedure. I think the ultimate outcome of all of our clinical research is often leading to one of these 7 things. Implementation strategies, on the other hand, are evidence-informed strategies, or another way to think about these are system-level interventions. These are things that we are doing to the system, again, to try to get more people to do the thing. So these might be evaluative or iterative strategies, such as audit and providing feedback. They can be interactive assistance, such as external facilitation, having a team that's actually helping support people to do these things. It might require financial strategies, so altering fees or incentives, infrastructure change, adding new clinics, adapting and tailoring strategies, so being able to change somewhat of what that intervention or innovation is. Stakeholder interrelationships, so being able to work with local opinion leaders to be able to sort of better understand how to implement something. Clinician support, so like electronic medical record reminders, training and education, or consumer engagement, so social marketing. So these are just some examples, not of specific implementation strategies themselves. Just as, on the left-hand side of the slide here, I don't have specific evidence-based clinical or preventive interventions themselves, but different categories of things that are different implementation strategies that we might test. And so when we think about, doing implementation research, we're often thinking about sort of new clinician support tools that will, better help them prescribe a pill or refer to a program. We're thinking about different ways in which different financial strategies, billing fees or billing structures might support people, actually being able to refer to a specific program. We're thinking about different interactive assistants, so different, implementation teams that might be there to actually support the implementation. And we're studying the impact of these things on different implementation outcomes. So, to describe or talk a little bit about implementation strategies, as mentioned earlier, strategies are interventions on the system. And sometimes, especially early on in this field, people refer to these as implementation interventions. But generally, the field has moved away from that to try to be a little bit more distinct about, what is an intervention and what is a strategy. So we refer to these things as implementation strategies to separate them from the clinical innovations or clinical interventions. So again, these are things that help people to do the thing. These are methods or techniques used to enhance adoption, implementation, sustainment, and or scale up or out of a program or practice. So the other thing is that, these often do not have a direct effect on the clinical or patient level health outcomes that we're interested in. These are targeted on the innovation or intervention. And so by getting people to do those things, that's how we lead to the health outcomes. So it's not the implementation strategy itself that's going to lead to, better cardiovascular health, reduced depression, better quality of life, whatever it is we're looking at. It gets people to do more of the innovation that leads to those clinical outcomes. And these implementation strategies are often multi-level and multi-component, so that we are having them, have multiple sort of aspects, because system level change is hard. It's not easy to do any specific, any specific thing. And that evaluating the strategy effectiveness is the primary focus of implementation research. So this is the definition that NIH uses when they talk about implementation research. So implementation research is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings. As mentioned earlier, that these can be discrete. So for example, we can look at, the implementation of reminders to be able to get people to do things. They're often multifaceted and packaged, however, so we might see a combination of things such as training plus consultation. And they can also be blended and protocolized themselves. So for example, getting to outcomes is a standard evidence-based implementation strategy that's used in different settings to support implementations. And that they often target or interact with determinants to achieve implementation outcomes. So we often are trying to create or identify strategies that tie to some of those different determinants, to the different barriers and facilitators that we think about implementation to be able to sort of better achieve the implementation outcomes we want to achieve. And that there's rarely a one-to-one relationship between strategy and determinant. It's not that, you know, we go do a needs assessment and we sort of identify specific determinants and we say like, oh, okay, based on the fact that, you know, one of the things that we noticed in this is that, you know, provider buy-in is low, that leads to a specific strategy. There might be multiple different strategies that might sort of address provider buy-in. Maybe it's financial incentives, maybe it's training, maybe it's engaging key stakeholders and leadership, you know, can be various different things. And so, you know, coming up with implementation strategies often requires a lot of collaboration and coordination with the different settings and the different people that you're working with. So implementation research and dissemination research, I think, is very community engaged, very stakeholder driven, very collaborative in terms of you know, coming up with this type of work and these types of research questions. Here's just some examples of how you might sort of think about the linkage between an implementation strategy from the determinant, the strategy, and the specific mechanism. So this is just sort of an illustration of that like last point I was making, that we often come up with strategies to kind of address specific determinants. So for example, if we think that our determinant, what we notice in a setting is that one of the challenges to implementation is that there's a provider knowledge deficit, we might come up with a strategy that's focused on education or provision of information. And the goal of that is to build awareness or build knowledge of, you know, maybe a specific procedure, a specific referral, or specific program. Now, say, for example, you know, one of the things that we might sort of see as a determinant is a provider skill deficit. So it could be that, you know, the provider doesn't know how to do the specific procedure, or that they're not trained in a specific evidence-based psychotherapy. An implementation strategy there could be focused on training. So for example, teaching and practice with corrective feedback. And the mechanism we're thinking that we would address there would be skill acquisition, refinement, or mastery. Or if a challenge is in provider turnover, we might use a train the trainer model, which means training people in a specific setting so that they can train other providers in that setting, so that you have a person at a specific site that can provide continuous on-site expertise available for consultation. So that if you have a specific clinical procedure that might be somewhat complicated and is not something that individuals often get early in their training, you can train people at a specific clinical site to be able to train other people at that site to do it and to monitor them long term. So I think what's really useful to think about in terms of this aspect of implementation strategies, again, is that the strategies are meant to sort of deal with some aspect of the determinant, and that by focusing on the mechanism of terms of how you think that strategy might have an impact, this leads to research questions that you could actually evaluate and test in a sort of a formal evaluation of an implementation strategy. And so, you know, if we're doing clinical research and that's looked at sort of understanding the effectiveness of interventions, we can often use the same designs and the same sort of models of evaluation that we would use of implementation strategies. So I think that, you know, it's not like we have to throw away all of our knowledge of clinical effectiveness research or clinical evaluation when we do implementation research. It's just a shift in the way we're thinking about, like, what is it we're evaluating and what is the research question that's present there. So implementation research, as mentioned earlier, is a focus on strategies. And this is a sort of progression of implementation, you know, research across different stages. So in early stage, we identify determinants, we then select and tailor strategies. We then sort of move to more formal implementation research that is either piloting and evaluating specific strategies, comparing strategies against each other. So maybe comparing strategies in a head-to-head format to be able to determine if one strategy has comparative effectiveness to another. and then doing mechanism research to understand how and why they work. So again, I think a lot of the similar sort of research process development that we do in other areas of clinical research still applies to implementation research. It's just a shift in what the research question is and what we're evaluating. In clinical effectiveness research, we're evaluating the innovations and the interventions. In implementation research, we're understanding or evaluating the implementation strategies. So in light of that, when we do implementation studies, because we're not focused directly on the clinical outcomes, we're focused on, or the clinical interventions which lead to clinical outcomes, we're focused on implementation strategies. We have to think about like what are the outcomes, or what is it we're trying to assess as we are thinking about these programs we're trying to evaluate. So implementation outcomes, and this is a definition that Enola Proctor came up with in 2011, which I really love, is the effects of deliberate and purposive actions to implement new treatments, practices, and services. And an implementation outcome can serve one of three outcomes, although it can also they're not mutually exclusive. So you might think about more than one thing at a time. It could be an indicator of implementation success. So this could be sort of reach or adoption. They can be proximal indicators of implementation processes. So sort of things that, precursors to seeing implementation occur more broadly in a setting. Or they can be intermediate outcomes relative to the service system and clinical outcomes. So for example, we have to have an intervention reach a person before it can have a clinical effect. So going back to our sort of vaccine example I gave earlier, that unless someone actually takes a vaccination, you actually will not see a benefit of that vaccination on that person. So someone has to have the vaccine available to them. They have to decide to use it. They have to have a provider who's able to give it to them before we can actually see a clinical benefit. So implementation outcomes are focused on, indicators of implementation success, proximal indicators of the process, or intermediate outcomes that are describe the service system rather than the clinical outcome itself. Oh. Another picture problem, but I'll just move to this description of Enola Proctor's model then. So in Enola's model, the implementation outcomes that we sort of evaluate in implementation studies are things related either to acceptability, what are people's perceptions of the innovations, adoption, whether people will actually use it, appropriateness, whether it fits with a specific context and a specific setting, costs, how much does it actually cost to do the specific innovation or intervention, aspects around feasibility, can people actually provide it in practice, fidelity, are people able to provide it according to the way it's supposed to be delivered, penetration, which kind of speaks to the sort of relative percentage of individuals, clinicians, providers, practitioners who are using it in a given setting, and sustainability. Will it actually stay over time? Can it be maintained? Can it be consistent after it's introduced? And these are the things that we look at in implementation studies when we sort of evaluate the impact of implementation strategies. Any questions there before I move into maybe an example of my own work that I think encompasses some of these principles that I was talking about in terms of what is implementation research, what are implementation outcomes, and what is the target of focus in implementation work in terms of implementation strategies?
Quick question. This is Adam speaking again. I'm wondering how implementation strategies would differ from execution strategies, since execution would require a research or understanding of how the treatment or the clinical research will be implemented. Thank you.
Yeah, I'll say execution strategies is not a term that I've heard very often. I think that it could be really consistent. I think that if you're thinking about sort of execution strategies is research that's doing some like, maybe I'll actually just go back a couple slides real fast. If we think about sort of this model I have here, if you're thinking about sort of doing early stage planning around, what would it take to actually, execute or implement a specific clinical innovation, that's very much on this pipeline of implementation research. I would sort of say that that's at this sort of like first dot here of like identifying determinants of like doing some like, market research or, interviewing key stakeholders or working with like patient advocacy groups or patient groups, like really understanding some characteristics of, as mentioned earlier, like using the CFR model that I really like. What are some things we have to appreciate about the innovation itself? What about the settings, both the inner settings and the outer settings in which we're going to deploy it? What about the people involved? And that can be the providers, it can be the patients, it can be the leadership or the administrators. Any of the work that you're doing there is definitely kind of in the zone of implementation research. It's kind of the earlier stage. It's us trying to understand what are some of the characteristics or what are some of the aspects that we need to incorporate or think about as we design implementation strategies. But it's in sort of the realm. But I think more formal implementation research, as we sort of think about it, is research that then kind of moves to the latter stages of this, aspect in terms of thinking about like actually selecting and tailoring strategies and then evaluating those strategies. So, I think that if you think about, implementation research in those regards, it's like once you come up with the execution plan and the sort of strategies in which you would implement the clinical innovation, how do you actually evaluate whether that implementation is effective at getting, more people to do that innovation, and if they're doing it better. So, how much and how well are people doing that clinical innovation would be the implementation question there. Does that make sense?
It makes sense. Thank you.
Can I ask a question about that as well?
Yeah.
I might be just overthinking this, but and actually it's related to the previous slide and where those implementation outcomes fall on that arrow slide that you had on before. So like, where does this fit into that bigger picture?
Yeah, so the implementation outcomes are things that you would start to evaluate as the outputs of your implementation strategies, so that you would sort of be understanding some of these different outcomes as the how much or how well are people doing the things. I do think you can start to evaluate some aspects of these things early on. And I think that that's sort of a shift that the field's been moving to for, sometimes it's called design for implementation. In my area, more specifically, it's referred to as deployment focused development sometimes. But like really working with key stakeholders early on to sort of understand, would this be something that would actually be acceptable to them as a provider? You might talk with like system leadership or, medical, the staff of like the medical clinics of like, would this be appropriate for the sort of setting in which you're, providing care? You might sort of understand sort of better aspects of the costing, like how much would this actually cost? And would this be something that could actually be like reimbursed or, would be cost effective in sort of a setting of care in which you're going to provide it? So, these are things that you would evaluate as outcomes of implementation strategies, but you can start to explore them early on, maybe through interviews, through mixed methods work where you do surveys as well, or through other things that, better help you design, the innovation in ways that might be more appropriate for implementation, or start to help you think about like which implementation strategies might be most likely to succeed in the context in which you're going to deploy it.
Thank you, that helps.
Cool. So I'll move to an example, and this is actually an R01 project that we just recently got funded, and we're referring to this as the SUPERA project, or Supporting Peer Interactions to Expand Access. And so this is actually an NIMH, National Institute of Mental Health funded R01 project that is engaging in what is referred to as a hybrid effectiveness implementation hybrid, and actually hybrid trials. And this is a little bit more complicated than where I'm going to go into, but there's often referred to as like 3 types of hybrid designs, and this is a hybrid type 2. And so what that means is that we are simultaneously testing an implementation question at the same time as we're testing an effectiveness question. And the structure of this, the aims for this project actually follow that sort of logic, quite well. So what we're ultimately trying to do in this project is we're trying to better understand if we can provide digital cognitive behavioral therapy to monolingual Spanish speakers in a safety net primary care setting to improve better access to evidence-based psychotherapeutic practices and better outcomes in terms of depression, anxiety. What we're doing is we are randomly assigning we have 2 levels of random assignment, one that's focused on an effectiveness question and one that's focused on an implementation question. At the effectiveness level, we are looking at whether we're looking at the effectiveness of digital cognitive behavioral therapy, which is an evidence-based practice of interest for depression, anxiety. And we're randomizing patients to receive either a peer-supported digital cognitive behavioral therapy. So this will be digital cognitive behavioral therapy that's provided along with support from a community health worker, or standalone digital cognitive behavioral therapy. So this is self-guided digital cognitive behavioral therapy that the patients will be using by themselves. And this is a question of interest, and this is an innovation because although we do know that digital cognitive behavioral therapy works, we're not entirely sure if this community health worker model will be effective. And there's also not a ton of evidence with it with monolingual Spanish speakers. So there's still some aspects of the effectiveness that we want to sort of learn as part of this study. For the implementation question, we're actually doing a provider level randomization. So we're looking at 2 different implementation strategies. One that we're calling outreach, which is that we're going to go to the electronic medical record. We're going to pull the information of everyone on specific providers' panels who've been randomized to this implementation strategy. We're going to pull their information, and we're going to see, who has information that says that they are either depressed or they're anxious, that they have sort of symptom scores that represent that. And we're just going to send them information about the intervention directly. So this is direct outreach to those individuals. And we're going to compare that to InReach, which is more of like a warm handoff model where we're going to go train those providers in terms of this type of intervention and this type of treatment and the best way and the processes for referring their patients to this treatment if they think that it's appropriate for them. So in one way, it's kind of direct to consumer. We are just going to, go straight through, getting the information we have about them. And the other is this warm handoff sort of clinician referral. And we're going to look at the effectiveness of those different implementation strategies in terms of reach. Who are how many people do we sort of reach from each approach, and how representative are they of the sort of general clinic population? We're going to look at it in terms of adoption. What is the percentage of patients from each provider's panel that actually enroll and engage in this intervention as part of this? And we're going to look at it in terms of cost. Is one approach more sort of cost effective in terms of provider time or staff time in terms of getting people onboarded to the specific program? So those are all implementation questions. We're not looking at, whether or not InReach versus outreach leads to reduced depression or anxiety. We're looking at these implementation aspects of reach, adoption, and cost. And then lastly, in aim 3, we're trying to better understand the mechanisms of change at both of these levels. So we're going to be doing mixed methods analysis, including surveys, interviews, and focus groups. We're going to interview the different providers and the leadership in the clinic to sort of better understand their attitudes towards the intervention, the implementation climate, the clinic readiness, and potentials for sustainability. Is this something that actually seems like the clinic would be open to? Are there concerns that we would have to sort of better think about if we were going to kind of scale up or scale out this specific, intervention here? So you can see, hopefully, that this is a project that sort of encompasses some of the different aspects and some of the different characteristics I've been talking about throughout this talk. That there is some traditional clinical effectiveness questions, but at the same time, we're looking at this sort of implementation strategy, in-reach versus outreach, and we're using specific implementation outcomes, things like reach, adoption, and cost, to sort of understand the impact or the benefit of those specific strategies. Any questions about this, or is this helpful for people to sort of better understand how maybe some of those models and those outcomes and those discussions of strategies can actually lead to aims that can be evaluated in a research project? Cool. So speaking of research funding, I'm now going to transition a little bit. I'm going to talk a little bit about like D&I funding at NIH and some practical skills to think about like how you might sort of better sort of investigate different dissemination implementation funding opportunities, how you might think about sort of starting to craft your own dissemination implementation proposal. And as mentioned, I'm hoping that this section will be useful for folks, even if you're never thinking you're going to submit a dissemination implementation project. So just a little, discussion around, the NIH alphabet soup, as I say sometimes. I say here you have to know your RFAs from your PAs from your NOTs. So there are a variety of different mechanisms through which NIH is funding dissemination and implementation research. Some of these go out through specific funding opportunity announcements. And in funding opportunity announcements, there are sort of generally two types of announcements. There are requests for applications, or RFAs. These are usually more time-limited requests from NIH for specific types of research. There are also program announcements, or PAs. These are more sort of long-standing mechanisms that are ways in which NIH is supporting specific types of research. So for dissemination and implementation research, there is a standing now program announcement PAR. That's PAR 19274. Dissemination, implementation, research, and health. There are both an R01 and an R21 mechanism. So R01s are sort of big project grants, 4 to 5 year projects of $500,000 a year in direct costs. R21s are smaller projects. These are more pilot or planning projects that are sort of focused on earlier stage research. And a variety of different institutes participate in the PAR for dissemination, implementation, research, and health. So this is a listing of the institutes: NCI, NHLBI, NHGRI, NIA, et cetera. You can see. So, if you're thinking about the type of research that you're engaged in, if any of these institutes are institutes that you typically submit your funding or think about, institutes that fund the area of research that you're interested in, these are all institutes that have said like, hey, we want to see dissemination implementation research funded at our institution, and we're participating in this program announcement. There's also dissemination implementation that's baked into more specific program announcements at different institutes. So I have this example here. This is actually a program announcement that NIMH participates in. It's an NIMH specific program announcement. Clinical trials to test the effectiveness of treatment, preventive, and services interventions. I'm actually a member of the standing study section at NIMH, effectiveness in mental health interventions, that reviews all the applications that submitted to this PAR. And we also see a lot of dissemination implementation research that's submitted to this specific PAR. Another thing to sort of note is that in 2020, there was a reorganization of the healthcare delivery and patient outcome study sections. So as part of the terminology at NIH, a majority of the grants are reviewed by standing study sections. So these are sort of a group of the same reviewers that meet regularly to review grants. And these standing study sections typically have memberships of 2 to 3 years. So the same people sit on those study sections for about 2 to 3 years. In 2020, there used to be a study section that was called Dissemination and Implementation Research in Health. So they would review the majority of the grants if you were submitting to that program announcement that I mentioned, or doing sort of implementation research that was being submitted to a variety of different institutes. It would likely have been reviewed by the study section. As of 2020, they have a new standing study section. So this is referred to as the Implementation Science in Health and Healthcare. And so the membership of those study sections is public record. So I think one thing that I really always encourage people to do when they're submitting for grant opportunities is to look at the membership of those rosters and see if these are sort of folks that you know, the type of research that they do, and to see if your research would be a good fit there. I think it's really important to make sure that your grants and your projects are being reviewed at the appropriate study sections, because if the type of people who sit on those panels don't see your research as the type of research that they do or the type of research that they understand, it's unlikely they're going to give you, a good review of it. And so I think that understanding the makeup and composition of study sections is really useful as you're sort of submitting to funding, and understanding sort of the NIH sort of funding process and how things get triaged and moved to different study sections. But for dissemination implementation research, if the majority of projects right now are going to this implementation science and health and healthcare study section. So, what is it that this study section is meant to evaluate? This is a description of what types of projects are seen as being within scope or appropriate for the study section. So projects that identify, develop, and evaluate dissemination implementation theories, strategies, and methods designed to integrate evidence-based health interventions into public health, clinical, and community settings, and projects that have a major methods, strategy, or theoretical development component in implementation science to understand how interventions are implemented and measure implementation outcomes. I think if your project is going to the study section, and it will, as I mentioned, if you apply to that specific PA, it's important to appreciate that this study section is really thought about advancing the science of dissemination and implementation research. So they're really hoping that you will be developing and evaluating dissemination implementation theories, strategies, and methods, and have major methods and strategy or theoretical development. So if you're submitting to this study section, you really want to be using implementation science frameworks, models, and theories. Speak the language, show them that you know and understand sort of the standards of the field and different implementation theories and frameworks. You need to address a research and practice gap and advance the field of implementation science. So they really are seeing that you have a relevant health application, as well as sort of moving implementation science along, and that these projects require implementation scientists with legitimate full-time effort allocation to a specific project. So this, this study section is really a study section that is advancing the science of implementation science. And so I think that if you're thinking that this is a place that you want to apply, really making sure that you're teaming with implementation scientists or developing as an implementation scientist yourself, I think is really important for this study section. I think what we see in other study sections where implementation work might be reviewed is that often those investigators are applying implementation science methods, models, theories. And so they may not need the same sort of sophistication in terms of dedication of implementation scientists, and not the same focus on advancing the field of implementation science itself, as long as you're advancing knowledge and innovation in your specific field of study. So I think this is a really important question. And if you are doing work in this space, to think about, like, is this something that I want to be reviewed at SIHH, or is this something I would want to be reviewed maybe somewhere elsewhere where people might know about implementation science, but may not expect the same sort of theoretical contribution to the field itself. And I think the general point I would make for all of you all here, even if this is not an area that you're interested in, is like, if you're submitting NIH grants, it's going to get reviewed by some study section. And so understanding the sort of, as much as possible, you know, the expectations, the community, the, you know, the things that study sections are looking for, I think is really critical to think about, like, is this the study section I want it to go to, or would I want to try to get it to a different study section? So as I mentioned, you know, other standing study sections or special emphasis panels that review dissemination implementation work, they may be less consistent in expectations for implementation methods, terms, and models. Although the sort of flip side is they are probably not as well versed with different aspects of implementation science. So I think that you have to be especially careful to with the use of terms or jargon, and be sure to define and describe all those terms and frameworks. I've definitely been on some different special emphasis panels where I've been invited to kind of be the implementation science expert. So it's like there might be, you know, myself or maybe me and one other person who's talking about implementation science. And so, you know, although we're reading those grants and trying to represent the expertise, we're often explaining these concepts to people who don't have sort of a firm knowledge or a firm background. So it varies highly in RFAs and content areas. Always read the request for applications or the program announcement and use the language that's present in there. And I think the other thing I'll note, especially specifically to implementation science, is because it's a young field, we still see a lot of terminology differences. So in some areas of the world, they still refer to implementation science as like knowledge transfer. So making sure you use the terms and the terminology that's present in the RFA or the call for proposals. Again, this is best practice for any grant submission. I always print out the RFA or the PA before I submit to it and highlight it up and mark it up and like underline the different aspects where these are places where I feel like my proposal really fits well. And, you know, really remind the reviewers of the different places where my proposal is hitting. And it's best, as I mentioned, if you're going to a non-SIHH panel, to infuse implementation science into a more traditional research design and question. If it's really sort of advancing implementation science itself, it probably should go to SIH. So now I just want to show like two quick tools before I kind of close up for questions here. And these are tools maybe some of you are familiar with and some of you are not. The first tool I want to, you know, demonstrate is NIH Reporter. So NIH Reporter is a tool you can use to search different funded projects by NIH. I'm actually going to switch my share screen here and actually go to the tool itself. So this is Reporter. Actually, if I go back here, I'll just reload. This is the homepage I took the screenshot of. I love to spend time on NIH Reporter, especially when I'm preparing a grant application. It's really, really useful. You can just put anything into this box and search, but I actually really like to use this advanced search. You can search by a variety of different key terms. You can look at a specific funding mechanism. So you can actually, you know, look through different, you know, types of grants. You can also look for specific study sections. You can look at projects that are funded by a specific program officer, or you can look at specific FOAs or funding opportunities. So for example, I want to look at grants that are funded by the Dissemination and Implementation research PAR. Oh, this is the new one. I'm sorry, I have to pull up the old one because this one was just announced. 19274. So you can see like this pulls up all of the grants that were funded by that specific mechanism. And when you click on a specific grant, so I'll look at this one, you know, you can get a lot of information about that grant. You can get the abstract text, you get the public health system, statement. So this is a study that works to reduce firearm-related suicide deaths in young people by investigating the most effective ways to implement a universal safe firearms storage program in pediatric primary care. The study will include 151 clinicians and 32 clinics who serve about 40,000 youth annually in 2 mental health research network health systems in Michigan and Colorado. All 32 clinics and the 2 participating health systems will receive gun safe materials, including brief training and cable locks. Half of the clinics will be randomized to receive an EHR implementation strategy, nudge, and the other half will be randomized to receive nudge plus 1 year of facilitation to target additional clinician organizational implementation barriers. So it's a really great place, I think, again, to get some ideas about like, what do some of these types of projects look like? Another thing I really like to do when I'm looking at these is I'll click on go down here to similar projects. So you can see other projects that are similar to the project that's funded, and you can kind of click around and look at things. So if I'm submitting to a PAR or RFA that's been around for a while, I will always go to NIH Reporter and I will look at some other folks who've got who've been funded by that specific mechanism. I mean, another way I use Reporter sometimes is, if I'm thinking about a project that I have and what's the next step for it. So, for example, this is the Supera project I was talking a little about earlier. This is a place where I maybe do use sort of similar projects here. And I look at other people who are doing sort of similar stuff to what I'm doing. So, here's a group that's doing a hybrid effectiveness implementation trial of group CBT in urban schools. Here's a group that's doing computerized substance use and depression screening and evidence-based treatments in HIV primary care populations. So I think that, again, this is a really good way to sort of get a sense of like, maybe who are some people out there doing similar research to you. Maybe that can help you find collaborators, other people that you want to like go read their work and understand a little bit more about what they're doing, because, they are funded to do research that in some way similar to your own projects. The other thing that you can do also, if you want to, is you can also restrict this by a specific funding institute. So you can do that here. So say, for example, you are submitting to National Cancer Institute, you can click NCI there. And that way you can look at only projects that are funded by that specific institute. So again, it helps you sort of understand a little bit better, like maybe what is your institute interested in? What's the type of work that they're funding from that specific mechanism? So I think, again, this is a really, really useful tool to be able to help you better understand, what's going on in the space. Any questions about NIH Reporter? How many people have used NIH Reporter before to kind of search for things as they're thinking about funding? I see some hands raised. Yeah, I really, really love it. As mentioned, I use it a bunch, especially when I'm in like the grant planning, period, to sort of better understand like what are other people getting funded out there. Questions on Reporter? Cool. So I'll switch back to my slides for just a second. So the other tool I want to kind of call out, and I think is really useful, is grant repositories. If you're writing a grant, you should always try to get an example of that grant and see some other examples of like the right ways to sort of format, the information. Reviewers, I think it's very important when you write a grant to make it simple so that reviewers can understand it and go through it without a lot of cognitive complexity. I think reviewers also have certain expectations about like what grants should look like. what the language should be like. I think there's also different ways to best present information. And so I think seeing like a lot of examples is really useful. This is my favorite reason to serve on a study section, is that it allows me to see how reviewers are processing different information. What about grants are like their kind of consistent hangups? What are the things that they, talk, like what are the discussion points that, get discussed a lot about? But I think until you get to the stage where you're serving on study sections and you have that opportunity, examples of grants is like the best way to sort of get some information about that. So I wanted to shout out, just first, UCI here has a grant repository through the ICTS. This is the last link that's present here. It does require access. Marguerite's actually sharing some information about this in the chat, so that you request access to the grant library. And Marguerite, you can probably correct me. I think you get access for like 30 days or maybe longer, but then you have to get it. You can get it renewed very easily. And those grants are viewable from the different library. You can see there's like different examples of grants. There's K awards, there's diversity supplements, there's loan repayment applications, there's F grants, there's T awards. There's a variety of different things that you can get through that repository. I've submitted some of my previous grants in there. I think it's a really great resource. And so if you're having trouble finding a mentor or finding someone to give you an example, the ICTS resource is great. It's broad as well. So like there's lots of grants from different areas. In the specific area of dissemination implementation research, there are actually like two really great resources. One through UNC and one through NCI that provide examples of successful grants. I have those two links here. I want to just provide, show you what those look like a little bit. So this is the UNC website. You can, if you Google Imp Science UNC, you can see these, you can get to this website. They've got sample grants, they've got funding resources. You can organize it by year. So these are ones that went through the DARH study section specifically. You can see there's different mechanisms. There's R01s, there's R21s, there's R34s. You can click on the grant. Take a second, but it'll load up. And you can see they've got the grant that's provided here through the through this repository. So I think it's a really good way, you can actually go and look at, read a lot of examples of, published grants. And as mentioned, the National Cancer Institute also has sample grant applications in dissemination implementation science. Here you can see funded grants from a variety of different investigators. They list the FOA, they list the award number, they've got the investigator. Here's an example by Ross Bronson, a colleague of mine. This is focused on dissemination of cancer control. And I think what's also really great about this is you can see they've got like all of the different documentation that's present too. So all those additional forms beyond just, the specific aims and 12 pages that you have to write, you can see some examples of other things that are present here too sometimes. So again, I think just like reading these and getting some examples of ways to frame aims, I think is really useful as you guys develop your own dissemination and implementation projects. I think can also be really useful for grant projects more generally. So, definitely don't go and work on some of these projects, write up a grant if you haven't seen the example before. And I think that if you're writing a mechanism that's new or more unique, I think that that's a place where you can find some similar resources too. So I think grant repositories are really, really useful. I want to make the shout out to the ICTS one, as well as these two specific ones in dissemination implementation. And that's it. We have about 20 minutes for questions and answers. I also do want to just share my information as well. So this is my email. Feel free to follow up. I'm always happy to chat about dissemination implementation. We also have my co-director, partner in crime, Miriam Bender, is a faculty in the School of Nursing. This is her contact information. She's also always very happy to chat with people in this area. But I will actually stop sharing now and it open up for questions.
Any questions or comments for Dr. Schueller?
I'd also hear if no one has questions in terms of comments, I would love to hear if anyone wants to reflect on some things that they took away from today's session, things that were new, things that they think could be applicable to their own work. Because as mentioned, I always love to hear what you all take away from this, and especially with an interdisciplinary group like this, I always find that people take away different nuggets of things.
I find the implementation science website from UNC interesting. I hadn't been aware of that. So is this some sort of center at University of North Carolina that put this on, or how did this website come about to being?
Yeah, there's a variety of different centers at different institutions that are really focused on supporting dissemination implementation work. As mentioned, here at UCI we have a dissemination implementation unit, but I think that there are larger groups that are doing dissemination implementation work. So that website was supported by the UNC Center, but I really do appreciate your question, because I also want to make a shout out to our sort of sister campus of UCSD has a dissemination and an implementation institute that has a variety of different, I don't know if they have example grants, but they also, they provide like a lot of trainings that have sort of advanced skills in dissemination, implementation, research, qualitative method training, D&I grant writing, and they're available to the broader community. So I do have a sort of shout out. I'll put the link to their website here in the chat. But if you're interested in getting more resources even beyond what we offer here at UCI, I really would encourage you to sign up for the UCSD listserv.
Hi, thank you for your talk. I had a question about, I'm planning on submitting a social media vaccine intervention, and I'm also familiar with type 2 hybrid design, and I'm just struggling a little. So I might want to talk to you as I'm developing it in the winter quarter. Because I'm adapting it in the social media context. So it's not this multi-level clinical intervention, which I have submitted that right before the pandemic and got scored, but then I kind of pivoted to social media because I didn't want to burden. I mean, the clinics were just overwhelmed. So I'll be developing it, but I'm always a little nervous, trying to meet all the different requirements or match it up with the study section. That's like my biggest fear, is like I don't know, there's like 3 standing study sections, but it is also about adapting and implementing. And so the grantsmanship involved in that, because not all the reviewers are always familiar with like adapting within the social media setting. So you have a different domain, but I might want to pick your brain about, I don't know what your digital interventions involve, because because I want to implement a vaccine actually across 2 different vaccines, but also inoculate against misinformation. So there's a lot of substantive research questions I'm interested in. But then I'm going, I guess, then I'm gonna then also, I could easily use an implementation framework and look at implementation outcomes, but I don't know if that's too much, or if the new implementation science study section will see it as too much if it's not purely viewed on, if it's not solely focused on advancing the science of implementation science.
Yep. Well, a couple thoughts. I mean, first I'll say, I say this all the time, there's no implementation without adaptation. So I think like, you know, the focus of implementation science is, you know, spreading evidence-based strategies. But I think that, you know, we appreciate that when you spread things, they change a little bit, they adapt, actually there's some researchers, Shannon Wiltsey-Sturman has done a lot of work in this space of looking at sort of frameworks for coding adaptations. So I think it's actually called the frame model is the one that they developed, where you can sort of think about like, what are the, you know, what are the adaptations that are actually occurring as you sort of are doing implementation. So I think that, you know, at least on the study section where I sit on, we definitely really appreciate that adaptation takes place. But I think that what we really are, what is emphasized to us through program staff, and then I think what also is true in terms of the way that, you know, the projects get evaluated on that study section, is that those adaptations need to be either kind of conceptually driven, or, you know, they need to be sort of measured or understood, or there needs to be sort of good justification for like why those adaptations are occurring. So I think you're pointing out, I just want to just really raise, I think it's a really generalizable point about adaptations, because it occurs like when we move things to new settings and we try to do things in like new ways, like we're seeing, you know, we see adaptations that occur. I think kind of talking a little bit about like, you know, study section fit and like who, you know, who is the best, where's the best fit. I mean, I think definitely, you know, reaching out to program officers that are associated with your institute and helping them, having them help you navigate that a little bit. That's not something I talked as specifically about in today's workshop, but it's definitely something I encourage young investigators to really engage in, is that the program officers are there to help you. And, you know, I think hopefully program officers will eventually be your, you know, friends and, you know, folks helping you like navigate this process.
Okay.
Some program officers are better than others, that being said. So I think that,
Yeah.
you know, some are more responsive, easier to get on the phone, easier to, you know, a variety of different things. But I think they can often sort of help, you know, speak a little bit more about generalities of like, you know, where might be sort of the best fit for these things. I'm always, you know, chatting with program officers to sort of help better situate the work that I'm doing. I do think if there is not like a clear like implementation, not just like an implementation question, but a place where you're like really advancing the science of implementation, like the specific study section SIHH may not be the best fit for the project. But, you know, maybe there is an implementation question that you would be interested in. You know, maybe you could find a, you know, a group that is, you know, interested in like doing sort of similar things. I do know that the group at UCSD is doing a lot of work in implementation science and vaccine aspects. And so, you know, maybe there's some colleagues there that would be, you know, good folks if you were thinking about that. I can definitely, I'd be happy to chat more and connect up, but I do think some of the questions you're asking about, you know, adaptation and things like that, lead to some really generalizable questions that is useful for everyone here. So thanks for sharing. I saw a question in the chat about how we access information about study section members. And so there's most of the grants that are reviewed by NIH get reviewed by the Center for Scientific Review. And you can actually go to their website here and click on, you know, go through some of the different study sections. There are also special emphasis panels that might be institute specific. And so you can actually also go to whatever institute you submit to or institutes you submit to and see the listing of their study sections that are related to those special emphasis panels. The rosters for study sections are submitted at least 30 days before the review occurs. And if you submit to a study section and you get back your summary statement, the review roster is appended to the end of your review statement. So the information is, publicly available. Maybe it's a little bit hard to sort of navigate sometimes, but you should be able to find it if you go either through the CSR website or go through your individual institute. And again, if you submit, you can also see the study section that's present there. I think also through Reporter, you can search by study sections, and then I'm fairly confident you can actually click on the roster, but you'd have to know what you're looking for if you're using that as a search term. If you look at a grant, I guess I can double check this. Should be able to see the study section that reviewed it. And then click on the roster. Yep, you can. So I'll share my screen again, just real fast and show you this on NIH Reporter too. Because Reporter does so many cool things. This is why I'm such a big fan of it. So this is just an entry that I clicked on that was open. But if you scroll down here, there's a lot of the details. So under other information, it's got the funding announcement, the study section, the institute. If you click on study section here, this was actually reviewed by the old DIRH section. You can click here and you can see the membership roster. Now, this doesn't have a membership roster anymore because it's not around, but I can go back to 2018 when it was still. And here I can click on the meeting dates here on the right-hand side. And this will list the chair and all of the members of the study section. I should say, as I'm sharing this information, never contact a member of a study section, never ask them any things about reviews. That is not kosher. But you can look at who's there and look up their research and read their papers and understand, who comprises that study section. So study section members, the review itself is confidential, so you can't actually contact them. Don't ever do it. It's really bad. I hear stories about this happening and it boggles my mind. But it is, I always do find it useful to at least look at the composure of who's on those study sections. Even if you just look at the roster, it'll list their affiliations. And so you can get a sense of what schools are they from or what departments are they from, which I can find useful to think about the types of people who are reviewing these types of grants.
Great, thanks, Dr. Schueller. I think Dr. Kyosa might have had a question. Are you there?
Looks like maybe his audio is not up right now because I don't see the little microphone.
Yeah, I know he does it through his phone, and I'm trying to unmute him. But I don't think it's working.
Oh, now I see the little phone.
Oh, I think he just wanted to give you a shout out for mentioning our grants library and NIH Reporter.
They're
So
really,
thank
really
you.
useful tools.
Any other last questions? Well, thank you so much, Dr. Schueller. This was a great session.
Thanks everyone for attending. Again, always happy to chat about these things. And if you do have specific questions specifically related to dissemination and implementation work, please do reach out to the D&I unit. We're happy to chat and help support folks here at UCI.
Thank you, everyone.
Thanks all. Take care. Bye.